Now let's say you find a nodule and they're not feeling any pain. You could have latent trigger points, because there is such a thing as this. What we just talked about is an active trigger point. A latent trigger point usually doesn't bother someone until it is palpated. But you can also have little soft tissue, benign tumors in the arm and so forth. So you have to be able to recognize and distinguish between them. Okay, now we have to look at technique for helping to eliminate a trigger point. And again, I will use my model, so we will have to zoom in on my technique. And there's going to be a couple. There's the flat palpation, and that is like, if you can see this trigger point right there, I would use a flat palpation. I would use my thumb, or I can use my fingers, okay? And it's flat. And I would go with the fiber in a distal direction, in a proximal direction, and then apply the pressure. Okay? Then there's the pincher palpation technique. And let's go with this, and that would be where I would grab that area with the trigger point in it, and I would hold it, perform the pressure, start to work my way out, and I'm pinching the whole way through that, okay? So it's more grabbing and you're pinching as you're coming to the end of the skin. And you would find that a lot, you know, up in your axilla. You can use that. Some people have a preference on using their flat palpation versus the pincher. That's totally up to you. So what are the differences between trigger point and myofascia? Now, we've already established that the myofascial trigger point has essential diagnostic criteria. And just refreshing you is the painful nodule, the patient recognition, and the taut band. Now, myofascial treatment is different from myofascial trigger point. The myofascial release, we should say, is more of a philosophy of care. It's manual contact, gentle touch versus heavy touch. Your heavy touch is going to be more of your trigger point releasing, which is a component of your myofascial release. You have highly interactive passive stretching during myofascial release treatment, which at that point you're elongating and releasing the tightness or the restriction that you're finding in a muscle. And that restriction that we talked about earlier is going to cause your decrease in motion. As you know, like if you have one wrist that's full range of motion and the other is not, most likely you'll be able to increase that range of motion following our treatment that we're going to discuss today. So myofascial release, myofascial therapy, is monitored by the patient's response. And what I mean by that is, if I'm working on the patient and I'm going with their body, I'm going with their muscles, I'm going with how they feel. If it becomes very painful, then we'll most likely back off. Whereas you remember we talked earlier with trigger point release, you are actually causing a lot of pain. So we're focusing on myofascial treatment on the restricted myofascia areas to correct the soft tissue dysfunction. Now your supinator stretch, I'm going to try to show here. You're going to have your elbow extended, okay, and I'm going to pronate her. The wrist is going to be in flexion with ulnar deviation, okay? Do you feel that at all?
Yes.
Again, the positive stretch sign is going to be that ulnar deviation. So if that hurts, I'm going to let up. Can you tell a difference on that?
Yes.
Okay. And then, of course, I'm going to also look out for pin sensation, you know, which, of course, you don't get. If they start feeling an odd feeling or feeling like a little weak, then you want to let up on that as well. Or sometimes with the pin, isn't there like a proprioception with the pin too?
Proprioceptive to the wrist.
To the wrist. So, and you know, and a lot of times with a lot of our patients, and when we talk about post-myofascial treatment, I get into a little bit of proprioception, because that's probably overlooked a lot. Even though you're probably incorporating into your clinic and your exercises, you got to know you are incorporating it, because coordination is off. And I mean, just the ability of, let's say your proprioception's off, at your shoulder blade because you've been carrying around a heavy cast, and in your therapist asks you to squeeze your shoulder blades together, and you just can't do it. It's because your proprioception's off. You see it with your patients all the time. You show them and you're demonstrating how to do a wrist exercises, and they're just not getting it. They're over, and it's some of it is their inability to comprehend, but it's really not. It's the proprioception's off as well. So it's probably a combination of that.